Everyone who's joined our call today. This is Debbie Melnyk, and you are on session 2 of VCSQI's TCPI project Pathway. We're going to cover a little bit of overview of TCPI to make sure everyone is on the same page, and then review 4 of the milestones. Let's see, I think I will go to slideshow view. All right. Hopefully you can all see my screen. So just by way of recap, we have put together 8 milestone classes during which we review the scoring and strategies for meeting them. The first 2 have already, the first one has already occurred. Actually, I have to fix this slide. We are in the improvement goals class today. So this is the last time we're doing this one, and it is being recorded. Next week, we'll focus on staff engagement, and then subsequently each week you see we've got different topics. The milestone numbers are first listed for specialty practices, and in parentheses are the milestones for primary care. Sometimes they're identical, sometimes there are different ones for primary care that match the particular topic we're focused on. So today's objectives are to provide a brief overview of TCPI and our organization, VCSQI, to review the scoring for 4 AIM-related milestones, 1, 2, 3, and 13, which is number 18 for primary care, to outline strategies for meeting each of these milestones, and to review the relevance of the 4 milestone scores to the phases. And then, as you have questions, you can, we'll open it up. So, what is TCPI? It's the Transforming Clinical Practice Initiative that was designed and is being funded by the Center for Medicare and Medicaid Innovation, part of CMS. CMS has funded several organizations to provide this free education and coaching. What we do is to help you meet your MIPS activity, as well as help you look at your practice and transform it to be become more of a value-based practice than perhaps you are today, and then ready to join an alternative payment model. So to complete the TCPI, we are helping you achieve a 3 on all of the milestones. There are 22 for specialty practices, 27 for primary care. Many are identical, but there are a few more for primary care, particularly focused around population management and coordination of care. So VCSQI, our organization, the Virginia Cardiac Quality Care, VCS, Virginia Cardiothoracic Services Quality Initiative, is a nonprofit organization first launched over 20 years ago in the Commonwealth of Virginia, focused initially on cardiothoracic surgery for practices in Virginia, now having expanded to cardiology and North Carolina as well. This contract with CMS, however, allows us to work with all kinds of specialties in all states, because the Transforming Clinical Practice Initiative is not unique to just CT surgery or cardiology. So 5 phases of transformation are defined in the TCPI effort. You can see them outlined here. Underneath each vertical colored box, in smaller font, are the milestone numbers that relate to the phase. Sometimes you'll see one milestone show up under more than one phase. For example, number 1, which is a milestone we're going to relate to today. The reason it shows up under more than one phase has to do with the score. So for some milestones, you only need a score of 1 to meet phase 1 requirements, but you need a score of 2 or 3 to meet future phases. So you see milestone 1 does not show up for the last phase, Thrive as a Business, which means a score of 3 is needed. The last time it shows up is for Achieve Benchmark Status, which is phase 4. So you need a score of 3 for milestone 1 to complete phase 4. So that's why a milestone can show up under more than one phase. The score for it differs for that phase. So about the milestones, there's again 22 for specialty practices, 27 for primary care, and scores for each milestone determine the phase completed. For example, to complete phase 1, a score of 3 is necessary on milestone 13, setting an aim, and we're going to talk about milestone 13 in a minute. Other phases require various scores for other milestones. So we're going to begin with milestone 13, or 18 for primary care as it is numbered. This milestone defines that a practice has developed a vision and plan for transformation that includes specific clinical outcomes and utilization aims that are aligned with the national TCPI aims and that are broadly shared within the practice. So most of you started off as a 0 when you joined TCPI with us. And that's because you hadn't been in this project before. So you had not yet developed a transformation vision. With Ivan or Sherri, this has been probably the topic of your first call after you completed your baseline assessment. This is the only milestone associated with phase 1, and you must score a 3 in order to complete phase 1. So what is a score of 3? It says that you've developed and shared a vision and a detailed plan that addresses your goals for transformation with a specific clinical outcome and utilization aim, along with the detail of how each of the aims will be addressed. So let's look at this a little more closely. On this slide, you see a CMS slide that lays out the 7 aims of the national project. See, the first one is nationally, CMS wanted to see 140,000 clinicians in the project. Aim 2 focuses on building an evidence base for practice transformation so that of the practices participating in this TCPI, together we can find effective ways for all practices in the country to transform and become a value-based practice. So it's like a big demonstration quality improvement project. Aim 3 focuses on improving health outcomes. And again, this is the national slide. So it says for millions of Medicare, Medicaid, and CHIP beneficiaries and other patients. Obviously, in your practice, you're not going to be improving health outcomes for millions. 4 is to reduce unnecessary hospitalizations. Again, the number nationally is for 5 million patients. 5 is to sustain efficient care delivery by reducing unnecessary testing and procedures. 6 focuses on generating $1 to $4 billion in cost savings to the federal government and commercial payers. And finally, to transition 75% of practices that complete TCPI into an alternative payment model. So we're going to be talking about some of these national aims as it relates to the milestones as we go through this class today. So let's go back to milestone 13. Some of you may not yet have seen the transformation work plan we've developed for you. What we've done is taken your, I'm going to show this first. We've taken your baseline assessment scores and pasted them into a file that's called a transformation work plan. That then we pasted actually in this tab called Inputs and Instructions, and by pasting your scores there, it populates these other tabs, including developing a practice plan for you that lists the milestones you did not yet score a 3 in.
Oh, come on. Did you die?
Uh-oh. Belinda, we can hear you.
Sorry. I don't know what happened.
That's okay.
My earbuds came off.
That's okay. We can talk you through this later if you don't see the screen now. It's being recorded. Okay, so now I'm going to go back to the previous slide, which is actually, whoops, I didn't do that, did I? Which is actually going to be this tab, Aims and Measures. So, no, it's going to be this one, Visioning and Aim Statements. So in this tab is where Sherri or Ivan or I will work with you to select a measure that you're going to focus on. And this is an example from one of our practices that joined over a year ago. They decided they were going to focus on improving documentation of current medications in the record. So on this page of this Excel file, there's actually a drop down which allows you to pick which of these national aims your project focuses on. And in this case, improving documentation of medications in the record will help to improve the outcomes of your patients, because your clinicians will know the medications the patient's on. You'll know what medications the patient needs to be educated about, all of which should improve the extended outcome for your patient. So you'll pick the aim, and this is also a drop down that allows you to select increasing, decreasing, improving, reducing. There's words in here that you'll pick, one of which the best represents what you want to do with the measure. So again, this practice said they're going to increase current medication in the records by, and this number you get to put in. So they put in by 70%, and you get to put in the date. So they said by the end of this year, they want to see a 70% improvement from their baseline rate of current medication in the records. Once this vision is established, you have met milestone 13, and you have completed phase 1 and can now move into phase 2. So again, all of that will help you with, if you've not done it yet, by looking at your transformation work plan together and developing your visioning and aim statement. So, milestone 13 strategies. I'm going to go back here one more time to set you up for the next slide. One of the really nice things about this transformation work plan is that change tactics are built right into it. So you can see here, milestone 13, your score is a 0, tells you what the milestone is, what a score of 0 means, it's your score, and what actions you need to take in order to change your score. Next to that is a link. And if you were to click on this link, this is just a screenshot now, so I don't know that it would work. It would take you to this tab and very specifically to the tactics that you can put in place to meet this aim. So on the next slide, we actually just copy pasted the tactics from that change package tab. So these are the strategies to be used to meet milestone 13. You're developing a roadmap. You're stating your vision in measurable, bold terms, and you're sharing it with the staff. You're including your staff as you move through meeting your percent increase or decrease, whatever you put in that vision statement. And the staff are participating in helping that improvement occur and be sustained. So that's it for milestone 13. Again, it's the only one associated with phase 1. and it'll be the focus of one of our first calls with you if that's not already happened. So I'm going to turn the program over now to my colleague Sherri White, who many of you know, and she's going to write us through the rest of this web class. Sherri?
Thank you, Debbie, and good morning, everyone. Hope all is well. So let's focus on milestone number 1, which was the first question or the first statement you heard when you took your baseline assessment. This statement reads, the practice has met its targets and sustained improvements in practice identified metrics for at least 1 year. So in this regard, you can rate yourself as a 0, 1, 2, or 3. And a 0 states that you have not identified any metrics. A 1 indicates that you have identified metrics, but not showing improvement. A 2 would mean that you are showing improvement, but is not yet stable, or you haven't reached its targets. And a 3 would mean that you have improvements in place, identified your measures, but you haven't sustained them for a year or haven't achieved at least 75% of your targets. So in this regards, we tend to work with you to look at your quality measures and figure out how you're collecting it, look at your numerator and denominators, and help you to drive change in that regard, which would mean potentially looking at the different milestones that we go over and drive change specifically to that specific measure. Debbie, what's in the next slide? Okay.
Okay, let me just ask or add, Sherri, or ask.
Sure.
It is entirely possible that when you've joined the TCPI effort with us, you have already been tracking a measure for more than a year that you've sustained improvement upon. Correct, Sherri? So this isn't one that they necessarily start with us. It's already need a 3, right?
Yes, that's totally correct. And I'm sorry I didn't mention that. So Ivan and I, or Debbie, tend to ask you to look at your MIP scores. Have you participated in MIPS last year? And we would ask for that data, and that data would help us to see, have you sustained your changes or have you sustained or your quality measures for at least a year? That data helps us to see that. And also by analyzing that data, we can see what improvements needs to be made, and we can help drive change to make sure that it continuously goes in an uphill progression. However, there are some quality measures that you track that are inverse measures, which means a score of 100% is not what you want. The measure is, I'm thinking at the top of my head, hemoglobin A1C. So you don't want 100% in that quality measure specifically. The lower the score is, the better. So we'll help you to identify those different measures to see which end of the scale would be better for you in that regard, or to pay attention to. So this slide here shows the different change packages associated with milestone number 1. And again, the change package are suggestions, ideas, best practices that other practices are using to help to achieve a score of a 3 in that specific statement. So an example of that would be to select a quality measure, like milestone 13, identify what that quality measure is. Analyze that data monthly. There are some practices that analyze the data quarterly. When you're using claims, your system has some type of way, it should have some type of way to record your numerator and denominators to help you to see the progression over time. And in your EMR has the capability to build into your administrative settings the MIPS quality measures to help also track over time as you see patients. We help you to analyze your data, select the appropriate quality measures, and also use this as a mechanism to help drive change or improve your performance scores. Okay, yes, thank you, Debbie. So for the next milestone, milestone number 2, it reads, the practice has reduced unnecessary tests as defined by the practice. And again, I want to state as defined by the practice. Some tests work well for your practice, some doesn't. every practice is different. So again, you have to know what is best for your practice. And in that regard, reduce the unnecessary tests. So a 0 would mean you haven't reduced any necessary tests, nor are you looking to reduce any necessary tests. At the baseline assessment, if you were not, if your practice didn't do any type of tests, then your score would result to a 3, which means that it's not applicable. I can never say that right, for your practice, which is also okay because, again, this is specific to your practice. A 1 would mean that the practice has identified tests and will focus on reducing it, but it has not yet saw a reduction. And a 2 would mean that the practice has established a baseline and is regularly monitoring the metrics, but no improvement has yet been seen. And a 3, again, either is not applicable to your practice or you have seen and can demonstrate improvement in reducing unnecessary tests. So what are some, yes?
Can I just give an example here? So let's say you're an orthopedic practice and you have received a new patient referred by a primary care physician or the ER, maybe, and the working diagnosis is a fracture somewhere, not requiring urgent care necessarily, but so an example here would be, was an x-ray already done in the ER or by the primary care physician? And is it really necessary for your practice to repeat that x-ray? So here, you know, measuring it in advance, you might, it's hard, I think, for a practice to say, oh yeah, we've been measuring unnecessary tests already because it sort of admits something. But you might begin to think about tests that that are important to the type of care you provide and begin to look at, have we maybe been doing more of these than we need to? Which would get you to a 1, at least identifying the test. And then maybe in hindsight, going back through, you know, a time period to get some kind of baseline so that you can determine if you've made an improvement by revisiting each patient when they come to you to determine if the test that's necessary for you to confirm the diagnosis and provide treatment was sufficient. Sometimes it's not, and you have to repeat it, or you do a different kind of test. So getting to 0 may not be possible if a test was done and, you know, it wasn't sufficient, or, you know, in the case of an x-ray, it wasn't a good x-ray. But anyway, that's kind of an orthopedic example. Obviously, you have to look at your own practice and determine if there are tests that you routinely do or need to confirm diagnosis and plan treatment, and if that test has already been completed. Okay, thanks, Sherri.
No problem. Thank you. Okay, so the next slide, I wanted to give a few examples and to share how to know what tests are unnecessary. So Debbie gave an example for orthopedics. Another example would be lab work. If you know your patient, or you can just ask a patient, have you had any recent blood work? And you'll just reach out to their PCP or their other specialty provider and have them fill out a medical release, of course, and have them send those records over to you. That, in turn, helps to reduce unnecessary tests because you're not repeating it. Of course, you know, for the ones that I work with, you know, my background is in oncology. And oftentimes, the few of the physicians that I work with, they would repeat the test because it was done at an outside facility and they didn't trust the test. However, the national standards of lab work are all the same. So in that regard, the repeat of the test was not necessary. So think of it in that mindset. Work with your patients, have them involved more so in their care, asking them what tests have they done in the past, and also establish that teamwork and open communication between other providers to know what tests that patient has had or will have, and therefore you're reducing the unnecessary tests. Another way, or how do you know what tests can be reduced? or another way to look at this, each year, as a provider, you are expected to participate in CME activities, continuing medical education activities through your professional society. At those conferences, they introduce you to new ways of measuring specific illnesses or testing for specific illnesses and applying it to your practice. So this will be a good way to understand what tests can be reduced and how to reduce them. You can then work with your EMR vendor to add algorithms, if you will, into your EMR system that will prompt you to order specific tests based on conditions. Another excellent tool is the Choose Wisely website. It's indicated here, www.choosingwisely.org. This is an organization that was established, or website established by the American Board of Internal Medicine, specifically for the purpose of reducing tests. It gives you examples of tests that can be reduced or should be ordered by specialty, by state, I believe, and by the specific board. So this is an excellent tool to always refer to when you're looking to see if tests can be reduced or not. Okay. All right. Thank you so much, Debbie. Okay, so now we talked about reducing tests. How can we reduce unnecessary hospitalizations, which is milestone 3, which is the third milestone that was given to you during your assessment. What a 0 means is that there is no, the reduction of unnecessary hospitalization has not been established, put into work, thought of. A 1 would mean that you have established a baseline. You're getting reports from the hospital and you see that there are some hospitalizations that could be reduced, but you haven't yet done anything about it yet. 2 means that you have that baseline and you're now developing a process to reduce those unnecessary hospitalizations. And the 3 means you have a process in place. You're now able to see what the processes that you implemented played into the aspects of the hospital reduction category. I hope I said that right, but yeah, that's what a 3 means. So what are the strategies to help with the specific milestones? The strategies that would work with this would be to measure the readmission rates for the patients you treat in the hospital. So in this regard, in your specialty, you are experts. You know your patients. You are aware of medications that they can take and how they take it that would prompt them to be admitted to a hospital, for example. Proper education in this regard, making sure that they know how to take the medication appropriately, who to call if they experience any issues. Many of the practices that I work with have 24-hour nurse lines, triage lines available, and therefore you can kind of triage the patients over the phone to tell them what they should and should not do to avoid that hospitalization. Many of the practices that I'm also working with amazingly make home visits to the patient's home to help treat them over the weekend and late at night, just to help reduce that hospitalization. But some things you just can't prevent. Sometimes there may be a patient that is admitted to the hospital, but there's things that you can do to make sure that they're not readmitted. And again, that involves making sure they understand their discharge instructions, how to give proper wound care or treat their wounds properly, and how to take their medications properly. Because I believe one of the most recent or most highest level of readmission rates has to do with the improper care that they don't follow the instructions they were given. So just making sure they totally understand what their expectations are, having them to be more involved in their own care, and if they're not health literate in that regard, bringing in a family member to help them understand what they need to do, and also making a phone call just to check up on them would also help to reduce those hospitalizations. So those are a few examples. So at this regard, I haven't had my coffee yet, everyone, I'm sorry. So we're now at the end of our program, and we would love to open up the floor to any questions you may have specific to your practice or anything that we had went over.
All right, well, go ahead.
Yes, it's Juan Ibarra from Surgical Healing Art.
Hi, Juan.
Yeah. When I expect to receive the full practice plan?
Yeah, Juan, do you have a call scheduled with Ivan or Sherri already?
No.
Okay, well, we will get back to you individually and get that set up, and you'll get the practice plan, and we'll review that with you at that time.
All right, thank
Okay,
you.
Sherri, let's make a note.
Debbie, I'm sorry, I can't hear him. Can you repeat what he said?
He wants to know when he's going to get the full practice plan
Okay.
for him.
Which practice is that?
They're the Surgical Healing Arts Center.
Okay.
Dr. Abar and I had the baseline assessment. I think it was a week ago or so.
Okay. Sounds good. So we'll definitely reach out to you and schedule some time to go over your practice plan and dive into this process. It'll be fun working with you.
Thank you. I have one last question.
Mm-hmm. Go ahead.
Yes, it's about this presentation. What is the recommendation that you normally, or guidelines that you follow to choose the MIPS quality measure? I have 2 years doing it already. We chose measure that I believe that was good for us to follow, but I don't know if you have any guidelines that you follow to recommend practice. Like you must be, like, because there is many measures that we can choose. We are performing too good, but maybe that is good because I choose the quality. I choose the measure. That doesn't mean that we are improving quality using that measures.
Right. Yeah. We certainly can talk with you what measures you were using and what ones are applicable to the practice, and offer some suggestions for that. So either Sherri or I'll have that conversation with you in detail on the individual call with you, okay?
Okay, thank you.
Sure.
I have a question.
Go ahead.
So my question is regarding, like, one of the examples was to reduce unnecessary hospitalization. And Sherri had said that making a phone call or just going over discharge instructions with patients. Do we record it in their chart after we talk, and how do we track that?
Yeah, good questions. Usually when we're talking about readmission to a hospital, in order to get a handle on your patient's readmission rates, you really need to be working with the hospital, because they are measuring readmission to the hospital. I can guarantee you that. So they'd have to help you, or they would have to, kind of sort through their data and find the readmission rates for your patients. Then, if it's too high, not what you'd like to see, getting underneath the education the patient is given to help keep them out of the hospital is what this relates to. Let me go back to that. So often it is the hospital staff who are doing the discharge teaching and the discharge planning, the case management staff, the Office of Quality. But you're the one, it's your practice that knows the specialty and that knows the type of education the patient or family may need about their post-discharge healing or, care. So you need to provide to the hospital and quality the type of information you want provided to the patient. And it may also be your clinician at the bedside giving some final teaching instructions. Yes, it should be documented in the record what the patient received or the family member received in terms of education about their medication, about their incision if it was a surgical patient, about when to call the physician or or even primary care, and when to call about what. You know, if the incision is suddenly bleeding, you better call. Or when to go to the ER and skip the call. So that kind of detail can often be summarized in a document that is included in the patient's record as well.
And then we somehow just keep a list of those patients on the side. So we, if need be, we can provide a list of these other patients that we did this measure on. Or, got it. One more question. So we are in a podiatry practice, but we have very sick patients, and I can think of a couple of patients that have been in the hospital 2-3 times already, but it had nothing to do with the podiatry related issue. Do I still keep track of that, or do I just keep track of what got them, like something foot issue got them into the hospital?
No, this would be related to the care that podiatry has provided. If they were, admitted to the hospital and the podiatrist needed to admit them to do something, and they readmit,
Okay. Thank you.
All right, well, you all know how to reach us individually if you think of other questions. Next week, our program will focus on staff engagement, teamwork, and joy. And again, we'll repeat that Tuesday morning at 7 a.m. Eastern Time, 5 p.m. on Tuesday Eastern Time, and 10 a.m. on Friday Eastern Time. Recording them and posting the best of the 3 with those who can't make it. Sherri, any other concluding comments?
No, thank you all for your time. I appreciate you taking the time out of your day to listen to this fabulous presentation that we love to offer. And if you have any questions, we'll discuss any additional questions of how we can personalize or apply these milestones specifically to your practice. But I hope that these help, these sessions. Have a wonderful weekend, everyone.
Thank you. You too.
Thank you.
Thank you.